We're open to comments, questions. Yeah. Identify yourself. Good.
Thank you. My name is Deborah Kestel. I work for the Pan American Health Organization. I'm going to present tomorrow a summary, hopefully, brief summary of the situation in Latin America and the Caribbean. But I could miss the opportunity to say a word to these presenters today because I find that, the situation between the US and Latin America and the Caribbean is hard to compare. It's so far from, well, but some of the issues that are happening here, I would say, thank God we don't have those problems in many Latin American countries. Now, while listening now to you, when Harvey was saying a couple of times, we need you, and I was thinking, we need you. We meaning Latin America and Caribbean that I kind of represent now here, because it is so weak, the movement of recovery in most of Latin American countries and the Caribbean countries, that is so hard to work with. There are a few exceptions. We had organized last year the first regional meeting of Latin American Caribbean countries, movements of, we call them users. I know that nobody likes one or the other name, but that's the way we have called, and we have invited associations of users and family members to come, and there were representatives from around 30 countries. In some cases, it's one person working in the country, but it's a beginning, right? And we try to get some people from here because of the strength that you have, the power that you have. You need these people, but it's amazing, believe me, from an outsider point of view. It's amazing the work you are doing and the fact that you are here telling it to us.
But thank you so much. And I just want to say that Latinos and African Americans in this country are disproportionately represented when it comes to forced treatment, forced hospitalization, and incarceration, particularly incarceration. We didn't get to talk about solitary confinement and the overuse of that. So the lack of cultural and linguistic competence is a failure of our system to properly penetrate those communities. And I'm just glad you raised that issue.
I want to make a comment on this point also. It's true. I realize from going to Europe and Asia, haven't yet been to Latin America, but this movement of recovery and self-help and peer support, it did start in this country. And it comes from a tradition of self-help in this country. It is fairly unique. And my worry is that with this backlash that's occurring and the emphasis on outpatient commitment and coercion, and also I'm worried about the effect of integration with medical health care, that medical doctors do not understand our movement nearly at all. So we have to not only get our movement out to other countries before the medical people get there, but we also have to ensure that it retains its vitality here. So that's my worry about this emphasis on violence. Yeah.
Well, I want to pick up on something that you were saying at the very end about the end of the community mental health center movement, or its rapid demise, in some sense, because I think it has a lot of implications for how we're going to see change or make change, or what will resist change, whether it's suicide prevention, violence prevention, victimization prevention, or whatever. And it's to remember, for those people who aren't so familiar or didn't live through this history the way some of us did, before the 1981 election and Ronald Reagan came into office, the community mental health center movement, well, I did, the community mental health center movement through NIMH was a direct relationship between the federal government funding stream and communities. So the place I work at now had its own community mental health center, got grants from NIMH. NIMH lost that portfolio. The states had pushed for basically a decade or more against this movement because it had taken funds that the states thought should run through the states, through the offices of mental health or whatever they were called, and had funneled these to communities as a new form of funding for people in the general population, not people who had been in the state hospitals historically. And so this was part of this public health approach to community mental health, which was the community mental health center movement. And this came crashing down in 1981 with almost, at that time, the demise of the National Institute of Mental Health. Herbert Pardes in particular did a very good job of sort of saving the institute, but the funds were put into block grants that then go through SAMHSA to the states. Now in New York State and in virtually every other state in the nation, all of this money is then turned over to counties, and the disbursement is based on county policy. Now some of that's starting to change with the Medicaid revisions, but in fact, if you think of the 2000 election in the United States as a crazy quilt of voting chads, the mental health policies, the way services are delivered to people, the discrimination policies, the police policies, the commitment policies are all played out at the county level, or in New York City at the 5-county level, but nonetheless. So this is a very, in some sense, granular problem that has to be met at a granular level. And this is where I think, in particular, the grassroots organizations, the peer-driven organizations have a level of sensibility that I certainly say most clinicians don't have. They don't think about this in these policies. So it's very important, I think, to organize this in ways which have a sensibility of where do you press the levers of power and push.
Thank you, Eric. Can I, let me just say that Camelot may be reopening soon on the Broadway show house near you, because using the Americans with Disabilities Act, we now have a lever again to get people to kind of resurrect the dream of what it was all supposed to be about. And we have a better dream now, because what's being written into settlement agreements with states is not only mobile services, assertive community treatment, support housing, all this kind of stuff, but peer supports at the front doors being incorporated as part of the remedy to undo the civil rights violations. So this is like a new day.
So I think it is, and I actually want to disagree with you about your worries about the Affordable Care Act and the integration of mental health into Medicaid and other things. Mental health is going to become one of the biggest parameters for population health. And it is already starting to have an effect. We can see this beginning to bubble up in New York State. And for instance, we did a lot of peer support programs, but then they were unfunded as the state changed its way of paying for things.
Right.
We're now beginning to think about how we can do peer support, because when you get global population delivered funding, you then have much more priority, much more capability as a provider of shaping that in ways. And
let me just comment on that, because in Massachusetts it's sort of gone to the next step. So, you know, we have 100% people, 99% covered. So we thought, you know, okay, now peer support will be covered more, but they've encompassed under this ACO idea. Their ACOs, accountable care organizations, are now doing the dual eligibles, and there's no peer support on the horizon. They said, well, we don't understand peer support because we're medically driven. And what does a peer do? And why is a peer in the room anyway? We're doctors.
And that's very specific, though, to your state, Dan, because in New York it is opposite. But the Medicaid redesign, there's a meeting right now that I've missed called the Behavioral Work Group that I'm on, where we're shifting all the incentives because of the ACA to be provider accountable, hit the streets, a broader benefit package. Peer support is totally in the benefit package, so I totally agree with you. I think Medicaid redesign, because of the Affordable Care Act, changes the incentives and what the money pays for, and is the biggest hope I've seen in
Let
years.
me say one other thing, though, that also is difficult, and that is the model has not changed. As long as it's seen as individuals having a medical problem, a psychiatric, you know, brain disorder problem, then they'll have the same type of treatment, and peers are being trained basically to be young professionals and clinicians.
I think it's different in different states, and I think this really brings the point
I'd like to
back.
think so.
Our peers are in communities.
You don't have
on
the
the
medical model.
Yeah.
We have a medical model, Dan, but we have peer wellness coaches. We have contracts with managed care plans where we're not just getting people to take medicine.
Okay.
Right.
He's got a question up there.
First, I want to thank the panel. I thought that was extraordinary. And Bob for your comments as well. I think there are things that are worse than the medical model. And I think Bob, in his closing, gave us a sample of what might be coming, how the problem of violence could be used as the enemy of the recovery movement. Much worse than any medical model, but with very bad impact and very bad effects. If I were to read one of the slides from this morning, Paul Applebaum, he said, he quoted Wayne LaPierre, who was capitalizing on the violence. And he said, the problem of violence is largely due to people with mental illness, genuine monsters that are so deranged, so evil, so possessed by voices and driven by demons that no sane person can even possibly comprehend them. That is permitted is an effect of our Constitution, that we tolerate it without protest and without rising up is a warning sign. And I think that the same way that violence has been used to punish and oppress and prevent the real recovery movement and the recognition of human dignity and human needs, the warning that this might happen in other developing countries, in Latin America, in Africa, in Asia, in any place you name, is a very big threat, because the problem of violence is worse and the problem of inadequate mental health care and treatment is worse. So yes, there is potential for this to happen and be replicated. So I would agree with our colleague from PAHO that if you could somehow get the narrative together that warns of this danger and list some steps that might be taken to prevent it, we could intervene early. But I think the lessons from your stories, and both individual and the collective story, are so important, and they're lessons for us to pay attention to and to share very widely. And thank you for raising this to our attention and for your brave and important presentations.